Hello everyone, myself Dr. Surendran. I am an infectious disease associate consultant working in Apollo Hospitals, Chennai. Today we are going to discuss about intra-abdominal infections. Generally, abdomen is considered as a Pandora's box, and infections in this Pandora's box is mostly complex because we have different organ structures and different kinds of presentations which we can miss in the general clinical practice in our routinely. So moving on to the topic core. So this is a picture of different organ systems in the abdomen. So it consists of mainly the hepatobiliary system and the gastrointestinal tract and several other organ systems. So the hepatobiliary system consists of the liver, the gallbladder, the bile duct, and which are the main organs which help in excretion of the bile, which opens up into the duodenum. The other organ systems include the stomach, the pancreas, the spleen. So the pancreas can have infections like pancreatitis, the spleen can have splenic abscesses, the liver can have hepatic abscesses, etc. The other organ system is the intestinal tract, which includes the small intestine, the large intestine, reaching up to the rectum, cecum, and the anus. And beyond all this, there are few outpouchings called as diverticula in the colon, which can get infected. And there are other organs like appendix, which is a vestigial organ, which can get infected and cause complications in many patients. And apart from this, we have peritoneal coverings which can get infected, which we call as peritonitis, or there can be focal collections because there is the space called peritoneal space, wherein infections can get loculated and get collected, and which can also complicate. So before moving into the infection syndromes of the abdomen, we should understand the microbiota of the gastrointestinal system. So microbiota is nothing but the normal colonization which happens in the human body. Like our skin is colonized, the entire gastrointestinal system is colonized by loads and loads of bacteria. So if we see from above to downwards, the stomach, the small intestine, the large intestine. The stomach, the acidity is just 2. And it does not harbor many bacteria. The bacteria which usually colonizes the stomach is Helicobacter pylori, which we already know. And moving down towards the gastrointestinal system, we have the duodenum, the small intestine, which majorly harbor streptococci and enterococci, and lactobacilli as well. When we come down, it is predominantly colonized by gram-negative microorganisms, which we call the Enterobacteriaceae family, which includes the E. coli, Klebsiella, Proteus, etc. Apart from this, when we further move downwards, the gastrointestinal tract is colonized by multiple bacteria like anaerobes, which includes Bacteroides, Bifidobacterium, Peptostreptococci, Clostridia, etc., henceforth and so on. So, and coming down, you also have Streptococci and Staphylococci near the anal canal. So why this is important is that it is these basic microbiota which translocates or which are the causative organisms of the infections, which mainly contributes to the intra-abdominal infections. And because they can go through the peritoneal spaces or the organ systems through the venous plexus, through the lymph, or it can be direct translocation or through perforation, etc. So when we consider these bacteria, the majority of the bacteria which we see in the intra-abdominal infections are gram-negative organisms. So when we talk about gram-negative resistance, is a very important problem in India, so which we call as a gram-negative resistance. The two major mechanisms of resistance which is prevalent in the community is the ESBL, which we know as extended spectrum beta-lactamase, which means that these bacteria do not work for third generation cephalosporins basically, which are ceftriaxone and cefotaxime, etc. So when they do not work for these bacteria, we call them as extended spectrum beta-lactamase producing organisms, for which we have to choose higher antibiotics like a beta-lactamase inhibitor or a carbapenem. And because of the misuse of antibiotics or the inappropriate use of antibiotics in a lot of healthcare associated infections, we get resistance even to the higher antibiotics like carbapenems, in which case we are forced to use higher antibiotics like colistin and tigecycline, so on. So these gram-negative resistance will be dealt in with in a separate topic. But this is just a basic idea to know what antibiotics we have to choose for intra-abdominal infections basically. The ESBL rate in our community is somewhere between 30 and 40%. So anybody who comes with an infection in the intra-abdominal area should be covered for an ESBL producing organism. Otherwise, there is a lot of chance that we will miss the right choice of antibiotic. Moving on to the classification of intra-abdominal infection. This is just a basic classification. There are several classifications, but this basic classification shows what kind of infection it could be and how it could be treated. For example, they have divided it broadly into uncomplicated and complicated. Uncomplicated means the infection is contained in only one organ and it does not extend into the peritoneum. So there is only one organ involvement. The peritoneum is not involved. So that means the infection is easy to control even with antibiotics plus or minus surgery. Or even surgery alone can treat the infection without an antibiotic course of treatment. The other classification is complicated intra-abdominal infections, which means that the infection spreads beyond a single organ and it extends to the peritoneum, causing peritonitis, which means there is a complication, and this kind of infections mostly require a surgery and along with antibiotic treatment, which the duration of which will vary between 5 and 7 days usually. Now, moving on to the individual organ system infections. First of all, the most common thing is peritonitis. So peritonitis, which as the word suggests, it means inflammation of the peritoneum, because it can be because of an infection, it can be because of a chemical, etc. So what we are dealing with in infectious peritonitis. So the peritonitis can be diffuse or localized. So diffuse means the whole of the peritoneum is involved in a larger area. Localized means it's localized to a particular area where the primary problem is happening actually. So, and peritonitis is further divided into primary peritonitis, which is spontaneous, and secondary peritonitis. It can also be divided into community acquired and healthcare acquired. So let us see what is primary, secondary, and tertiary peritonitis. So primary peritonitis means, as the name suggests, it is a spontaneous peritonitis, which means that there is no particular intra-abdominal source. And this occurs mostly in patients who are adults, who have underlying liver disease like cirrhosis and ascites, and these kind of infections are mostly monomicrobial. For example, only one microorganism is the causative agent for this kind of infection. And more than 60% of the primary peritonitis, that is spontaneous bacterial peritonitis, is caused by gram-negative organisms, and very few are caused by gram-positive organisms. When I say gram-negative, it's mostly Enterobacteriaceae, which is E. coli, Klebsiella, protease, etc., with regards to intra-abdominal infections. The secondary is the most common cause of peritonitis. Here, it is characteristically polymicrobial. The secondary means that there is an intra-abdominal source. For example, there is a perforation in a particular segment of the bowel, which causes the microorganisms to spill over into the peritoneum and cause peritonitis. So in this case, whatever microbial load is there in that particular part of the bowel will be spilled over, and it should be polymicrobial in such cases. So it is usually associated with the microflora which is present in that particular area of the bowel. Tertiary peritonitis means it is a persistent peritonitis or recurrent peritonitis, which is a quite complicated one. So the other mode of classification of peritonitis means community acquired and hospital acquired. Community acquired means a particular patient getting this peritonitis comes first from the community without any hospital exposure or any antibiotic exposure. Why we have to divide like this is because somebody coming from the community will have the resistance mechanism which is just prevalent in the community because they are not exposed to long-term or repeated courses of antibiotics. So we'll have to choose the antibiotics accordingly. For example, if it is hospital-acquired peritonitis, that means that the patient is there in the hospital for longer periods of time or frequent hospital visits with multiple comorbidities and multiple antibiotic exposures, which means that their gut microbiota would have developed a lot of resistance mechanisms. When you choose antibiotics in those patients, you would consider a lot of infections which are resistant to the basic antibiotics which you would choose for a community-acquired patient. So you would have to end up choosing a higher antibiotic for such patients. The other infection which is there involving the peritoneum is the intraperitoneal abscess, which means collection of pus or abscesses complicating either a primary or secondary peritonitis, and it can get collected in particular spaces in the peritoneum, for example, the subhepatic space, the pouch of Douglas, the retroperitoneal space, etc. It also depends upon the most dependent portion or adjacent to the primary problem which is happening in that particular patient. And all these collections, it is very important to note that these collections has to be drained, which we call a source control in intra-abdominal or in any other infection, that these abscess or collection inside the intra-abdominal cavity has to be drained for the infection to get better. Only antibiotics will not cure the problem in such patients. So if you look at the organisms that cause complicated intra-abdominal infections, it can be monomicrobial, it can be polymicrobial. So if you see, it's mostly, the 82% is contributed by both aerobes and anaerobes. The aerobes can be the Enterobacteriaceae, that's gram-negative Enterobacteriaceae, and the anaerobes can be Bacteroides, Bifidobacterium, and Clostridium, etc. So if you see the facultative aerobic gram-negative bacilli, that's the Enterobacteriaceae which we discussed. It is the E. coli club, which is the majority of the organisms, sometimes Pseudomonas as well. And anaerobics, it's mainly Bacteroides fragilis and other Bacteroides species which can cause complicated intra-abdominal infections. So what are the investigations which we would opt for in patients with peritonitis? So in patients with peritonitis, we would like to analyze the peritoneal fluid or the ascitic fluid. So if an ascitic fluid contains WBCs, which is more than 250 polymorphs, that is neutrophils, then it indicates there is peritonitis, bacterial peritonitis, which is happening in that particular patient. So when you confirm peritonitis, you need to know what is the organism which has caused it. So that you can get with help of gram stain to know whether it is gram positive and gram negative, and culture which will help grow the particular organism. And ascitic fluid amylase and LDH helps in differentiating secondary peritonitis from primary peritonitis. The treatment is divided into empiric and targeted. So most of the time we start a treatment empiric, guessing what organism would have caused that peritonitis in that particular patient based upon community acquired or hospital acquired or prevalence of the resistance organisms which is there in that area, which is endemic to that area and that hospital. Okay. And then targeted therapy is when you know what organism has grown in the culture and what has caused the peritonitis particularly. So after knowing that, your duration of treatment will be 5 days for most of the uncomplicated intra-abdominal infections, which would be enough. So recommended agents for the treatment of complicated intra-abdominal infections. If you see the recommended, they have divided it into single agent and combination therapy. See, mostly in India, we would choose a beta-lactamase inhibitor, which you can see here is the piperacillin tazobactam. So piperacillin is a penicillin group, which is a beta-lactam, and tazobactam is a beta-lactamase inhibitor. So it will work for ESBL producing organisms. So, so that would be the ideal choice. The other BL-BLI, which is the beta-lactamase inhibitor, is the cefoperazone sulbactam. That can also be used for intra-abdominal infections. So they also recommend a treatment called the combination therapy, a cephalosporin plus an anaerobic cover, which would not be the ideal choice in India because we have a lot of ESBL in our community. So we would prefer to use a beta-lactamase inhibitor, or if the patient is very sick, we can use a carbapenem like meropenem, doripenem, or imipenem. And here they have recommended fluoroquinolones. Fluoroquinolones are not good options in India because we have the fluoroquinolone resistance in India with gram-negative organisms are very high. So we cannot depend on fluoroquinolones for empirical therapy in our set of patients. Intraperitoneal abscesses can complicate either primary or secondary bacterial peritonitis. As I already mentioned, the location is related to the site of the primary disease, for example, appendicitis, diverticulitis, biliary tract lesion, pancreatitis, etc. So usually, when it is an intraperitoneal abscess, because it is a secondary to a particular bowel problem, it is usually polymicrobial. And the investigation for this would usually be an ultrasound, which will help in assessing the site of the lesion, the size of the lesion, the echogenicity, etc. And CT scan is many times required to characteristically define the site and size of the lesion and the feasibility of putting a drain or approaching the cavity or the abscess fluid for diagnostic as well as therapeutic purposes, because one of the main treatment for this kind of intraperitoneal abscess is drainage of the abscess, which could be either ultrasound guided or CT guided, wherein we can place a pigtail which will keep draining the fluid. Sometimes if it is the patient is very sick, they may also need a laparotomy surgery to remove or debride the abscess, etc. So therapy is usually drainage, which can be ultrasound guided, CT guided, or open guided, as I already discussed. Antibiotics is similar to that of secondary peritonitis, and it is a polymicrobial target, and most of the time we will have to cover both gram negatives, gram positives, and anaerobes if it is lower down the gastrointestinal tract. So this is an example of an intraperitoneal collection, wherein the figure A, you can see there is an appendicitis with a air fluid level, that is the collection over there. In the figure B, what you can see down in where the arrow mark points is a diverticulitis with a collection, and because of that there is obstruction which has caused an obstructive uropathy on that side of the kidney. So this is an example of that abscess. In figure B, what you can see is a drain. The arrow points towards a drain which has been placed for the intra-abdominal collections, so which is the primary treatment. So without doing a source control, if you give antibiotics, the infection is going to recur or it is not going to improve in that patient. So drainage or source control is very important in intra-abdominal collections. Infections of the hepatobiliary system. So hepatobiliary system, as we already mentioned, it contains the liver, the gallbladder, the bile duct, mainly. So there can be separate infections which can occur in all these three organs. So the first one is the hepatic abscess. There can be a focal collection of pus in the liver, which we call as the liver abscess, and there can be cholecystitis and there can be cholangitis. So moving on to the individual topics, the liver abscess. So the liver abscess can be broadly divided into pyogenic liver abscess and amoebic liver abscess, because in India, amoebic liver abscess is quite common and it's one of the endemic part for amoebiasis. So with regards to pyogenic liver abscess, it means that it is basically a bacterial infection of the liver where there is organized pus collection in the liver. So it is actually a focal purulent collection in the liver. The route of entry for this bacteria to the liver can be, there can be different modes of entry, the majority of which enters through the biliary tree, which is 40 to 50%, and through the hepatic artery, which is 5 to 10%, and through the portal vein, and then it can also be through a direct extension or cryptogenic as well. And when we come to the amoebic liver abscess, it is an invasive complication of the intestinal amoebiasis resulting in a focal collection of non-purulent fluid in the liver. So this is the basic microbiology of liver abscess, so which is mainly gram-negative as we discussed, because that is very common. That is Enterobacteriaceae again, which is Klebsiella and E. coli, and very rarely gram-positive Streptococcus, Enterococcus, and anaerobes. And with regards to India, we should also consider amoebiasis as the major cause of liver abscess. So when you see a patient with a liver abscess, two things run in your mind, whether it is pyogenic or amoebic. So with the clinical data you have, it is very difficult to differentiate between pyogenic and amoebic liver abscess, because most of the clinical signs and symptoms can overlap in both these kind of patients, be it age group, even the leukocytosis, elevated alkaline phosphatase, single lesion, multiple lesion, jaundice, risk factors, presentations, everything can be similar between the two groups. So it is very difficult to differentiate only on clinical grounds unless you drain the fluid out and investigate to know what it is. So it is very important to diagnose liver abscess, because your treatment is going to depend upon what organism has caused the particular liver abscess in that patient. So this is an example, a CT scan of the abdomen which shows hypodense lesion in the liver, which is actually a hepatic abscess. So antibiotic therapy for pyogenic liver abscess. So since again here the empiric therapy would be a beta-lactamase inhibitor or a carbapenem for that patient with an amoeba cover, which is metronidazole, if you do not know, if you have not established the diagnosis. But it is very important to establish the diagnosis. For such patients, you have to send blood cultures, you have to remove the pus from the liver through an aspirate and send it for gram stain cultures. And whenever you send cultures from the intra-abdominal tract, you should also ask for anaerobic cultures, because anaerobes are also a part of infection in intra-abdominal infections. So the treatment of liver abscess mainly would be the drainage and targeted antibacterial or anti-amoeba treatment. Infections of the biliary tract. So when coming to infections of the biliary tract, we have made two major syndromes, which is the cholecystitis and cholangitis. So cholecystitis is the infection or inflammation of the gallbladder per se. Cholangitis is an infection of the inflammation of the common bile duct or the biliary ducts. So they usually present with pain in the right upper quadrant, fever, and Murphy sign. Murphy sign is whenever the patient inspires, there is a lot of tenderness in the right upper quadrant where there is the gallbladder is situated. And it can also present with Charcot's triad, which is right upper quadrant pain, fever, or chills and jaundice in a particular patient. So the modes of diagnosing infections of the biliary tract is mainly the ultrasound, which can show a thick, not only a thick gallbladder wall, also a lot of pericystic edema, collection, or abscess, etc. And a CT scan will definitely say what is the thickness of the gallbladder and the presence of infection and inflammation in that gallbladder area. And blood cultures are an important part of investigating infections in the biliary tract. Most of the times you would get a positive result if you send 2 sets of blood cultures. And with regards to microbiology of acute cholecystitis and cholangitis, is again the same. So it is usually gram-negative Enterobacteriaceae, that is E. coli, Klebsiella, and then Pseudomonas enterobacter, and again gram-positive organisms like Enterococcus and Streptococcus. So usually you choose a antibacterial cover, which is a beta-lactam beta-lactamase inhibitor, where piptase is chosen because piperacillin can also cover your Enterococcus, and or a cephalosporin sulbactam, but cephalosporin may not have an enterococcal cover, or a carbapenem, which you can choose in a sicker patient. So the recommended agents and regimens for empirical treatment of acute biliary infections. For this, I want you to concentrate on the highly severe infection, because that is what suits for an Indian setting, which can be piperacillin tazobactam or meropenem, doripenem. We usually do not prefer a cephalosporin plus metronidazole combination in our setting. Now moving on to infection in the pancreas, which is called as the pancreatitis. So pancreatitis is basically inflammation of the pancreas, and it can be because of an infection. It most commonly develops after acute pancreatitis. So pancreatic abscess is called as it is actually a circumscribed collection, and it is a complication of acute pancreatitis. Again, the microbiota is mainly from the gastrointestinal microbiota, so which can be anaerobes, aerobes, gram-negatives, gram-positives, and candida. So the diagnosis is usually by ultrasound, CT abdomen, which can show inflammation of the pancreas. If at all there is a necrosis, it can show pancreatic necrosis, peripancreatic collections, etc. And you have to differentiate between sterile pancreatic necrosis, which is usually common in the acute stages of pancreas within 1 week of pancreatitis, and the real infection of the pancreas, because both can present in a similar way that a patient presents just like a patient with a sepsis. But what actually is happening is an inflammatory response to acute pancreatitis itself. Okay. So what you have to send for from the infection point of view is that you have to send for blood cultures, and if at all there is a collection which shows gas, etc., that means infection is already occurring, and you have to drain that fluid and send for cultures. So whenever you are sending for microbiological workup, you have to send for gram stain, fungal stain, bacterial culture, and fungal culture, because Candida is also a part of the microbial flora which can complicate an acute pancreatitis patient. So the treatment is you have to target the gastrointestinal microbiota, like we usually discussed in the previous syndromes, and drainage of any infected collection is also important, and targeted therapy is based on culture of the drained collection or pus. Moving on to infections in the spleen. So infection in the spleen, the bacterial infections, when we say it is splenic abscess. So it can be, usually spleen will have multiple abscesses which can be very small, which we call microabscesses or macroabscesses. So the etiology of splenic abscess is very narrow. Only few microbiological organisms can cause splenic abscess, which includes Staphylococcus, Streptococcus, Klebsiella, Burkholderia, Pseudomallei, which can cause bilioidosis. And infective endocarditis can cause complications like splenic abscesses as well. So the diagnosis is mainly by imaging, which is ultrasound and CT abdomen, which shows the micro or the macro abscesses. So if at all you find the macro abscess, what you have to try, if you do not have any other source of any other collections elsewhere in the body, what you have to try to do is aspirate the collection and send them for microbiological tests like gram stain, fungal stain, AFB stain, and some very, very rarely TB can also cause splenic abscess. Okay. So, but very rarely you may also end up doing a splenectomy to diagnose and to treat pyogenic splenic abscess. And blood cultures are a part of any syndrome with intra-abdominal infection. The treatment is targeted therapy, so it is very important to establish the diagnosis in a splenic abscess patient. There is no point in giving empiric therapy in such patients. So the treatment is mainly targeted therapy after identification of the etiological agent, drainage of macro abscesses, and if required, splenectomy if the infection cannot be controlled on antibiotics alone. Appendicitis, which is a very common scenario which we see in our clinical practice, is one of the intra-abdominal infections. It usually happens because of acute inflammation of the vermiform appendix that is often related to obstruction. So, and it is usually polymicrobial because it is situated at the junction of the small and the large bowel. It can have a gram-negative and an anaerobic involvement, cause for the infection also. It's usually polymicrobial. The diagnosis is mainly clinical. Patient presents with fever, leukocytosis, central or right lower quadrant abdominal pain, and you can elicit a lot of signs in such patients as well. So diagnosis is clinical and can be guided by imaging like ultrasound and CT, whereas CT is more sensitive than ultrasound, but basically it is a clinical diagnosis. Treatment is mainly surgery and removal of the appendix, and if at all there is a collection, it has to be drained during the surgery. And very rarely in selected patients who are uncomplicated, with uncomplicated presentations, they do try with conservative managements with antibiotics alone, and or in patients who are poor candidates for surgery generally. Moving on to diverticulitis. Diverticular are small outpouchings in the large intestine which can get infected. So infection and inflammation of the bowel wall leading to microperforation of the colonic diverticula, which it's the basic pathogenesis of diverticulitis. And this also has a polymicrobial etiology, which is basically from the gut microbiota, which includes gram negatives, plus or minus gram positives, and anaerobes. It is usually diagnosed with guidance of the imaging. The treatment includes antibiotics for uncomplicated diverticulitis, and complicated diverticulitis patient has to be hospitalized and closely observed to look for any further complications which are happening. And in patients who are not treated with, who are not responding to antibiotics alone or conservative management alone, or who are in sepsis, or who have any complication like intraperitoneal perforation or no response to medical therapy, need surgery for diverticulitis. So these are the agents and regimens that may be used for diverticulitis. Again, it's the same. It is basically an ESBL cover, which is like piperacillin tazobactam or cefoperazone sulbactam, plus or minus an anaerobic cover, which will be metronidazole. Summary of empiric therapy in intra-abdominal infections. So this is a summary slide which generally summarizes what we have discussed earlier. So basically, when you see a patient with intra-abdominal infection, I would like to classify into community-acquired and hospital-acquired. The reason for the classification is that in community-acquired infections, the resistance rates are lesser. So what you would basically cover is an ESBL gram-negative bacteria for which piperacillin tazobactam or cefoperazone sulbactam will work. And if it is a hospital-acquired infection, you will expect a lot of resistant bacteria in them. So for them, you would choose a carbapenem or a higher antibiotic like tigecycline and colistin, where carbapenem resistant rates are higher if you expect that to happen in a particular patient. And whenever a patient has a complicated intra-abdominal infection, please remember that you have to drain the abscess or do a source control if at all there is a source which you have identified. And that is the most important part of treatment of an intra-abdominal infection, not only antibiotics. And then what are the other points which you have to consider is covering enterococci in particular patients, and then covering candida in certain patients. Wherever there is a delayed infection or a tertiary peritonitis or a secondary peritonitis or a resistant peritonitis, etc., you have to consider candida cover as well. And when you move down in the gastrointestinal tract, like the colon and all those things, you have to consider anaerobic cover, which is very important. So you may have to add metronidazole, though meropenem and cefoperazone sulbactam pip have some sort of anaerobic activity. There are few strains of Bacteroides which will be covered only by metronidazole. So it is good to add metronidazole when you move down lower the gastrointestinal tract. So to summarize, what you have to remember is that you have to send cultures, appropriate cultures. That is very important. You have to send blood cultures or the pus or the collection, whichever is there in the intra-abdominal cavity, through an image-guided or open-end drainage, and you have to send for appropriate microbiological investigations and then start empiric therapy. The targeted therapy happens when you establish the etiology of the particular infection. So I hope you would be able to choose the right antibiotic for a patient who is suspected to have an intra-abdominal infection. The first thing you have to do is define the syndrome in the intra-abdominal infection, send appropriate cultures, investigate, start empiric therapy, then change it into a targeted therapy. Then your patient will be treated in the right way. Thank you.